Someshwar garu, now we can start.
Yeah, thank you, Savan. Sir, with your permission, shall I start, sir?
Sure, ma'am.
Yeah, thank you, sir. Good afternoon, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our honorable and eminent speaker, Dr. PM Gopinath, sir, who is a director and senior consultant at Institute of OBG and IVF, Fertility Preservation Society of India, and SRM Institute of Medical Sciences, Chennai. He is a president elected Fertility Preservation Society of India and the member of International Fertility Preservation Society and a chairman of Board of Studies from 2016 to 19 at TN Dr. MGR Medical University and founder secretary IFS Tamil Nadu chapter and FMMC, FISC, FICOG and MBA and special training in fertility preservations from Shaba Medical Center, Israel, and a former professor of ONG Madras Medical College, past president of OGSSI, and awarded leading lights in ART awarded in IFS annual conference in 2018. And also he was awarded with the Icon of the Year in IVF South India 2019. So with this, we welcome you for today's webinar, sir. And today's webinar is streamed through the Shield Connect, which is a digital platform of Shield. I request all the delegates to please do visit Shield Connect webpage, and if you miss any part of this program, it will be available in the Shield Connect. So now coming to the today's topic, as we know that the WHO estimates that 9% of couples worldwide struggle with the fertility issues. In that, male factor contributes to 50% of the issues. So male infertility has a variety of causes and ranging from the genetic mutations to lifestyle choices to medical illness or medication. So now, without wasting much time, let me turn over the time to Dr. Gopinath sir to talk on male infertility and beyond. Over to you, sir.
Good evening, Someshwar, and thank you for your nice words. And dear team Shield and dear friends, it is indeed a pleasure to be with you to share some of my knowledge and thoughts on male infertility. As such, right from the beginning, I was interested in male infertility because 50% of the infertility is male. And I have an advantage being a male gynecologist. I have an opportunity to examine the male partners at ease and then put them into ease and treat them also. I had some of my very good training with Professor Anne Jacquer in Nottingham and Pivot, where I have specialized some of the skills on male infertility. Adding to all of things, COVID has done a great help to me. By sitting at home during the first lockdown, there was a program associated with ASRM where there was a course on andrology. It comprises of about 28 modules, and you have to pass all the modules, and then you become a board certified andrologist. The first COVID lockdown gave me that board certification, and every day I was doing one or two topics with which it was really enlightening. I thought I will share some of the knowledge, what I have just gained from that. The agenda will be semen analysis, what are the reference values, what are the diagnostic tests beyond the routine semen analysis, and then medication, how, when to use the antioxidants, and the surgical treatment of varicocele, if can it be improved, the success rate of ART, azoospermia, and what are the management of azoospermia, and what is there beyond male infertility, that we will come to that end of it. So as I mentioned that it is about 40 to 50% of the infertility male is a cause either directly or combined with that. It could be a defect in the count, or it could be a defect in morphology, or it could be a defect in motility, or overall it could be an oligoasthenoteratospermia. So how do we approach the male? So first is the history, where you read every time we are not going to take the history. So the first examination of the male, you take a detailed history and talk to him about his childhood, talk to him about his development, his habits, his occupation, his sexual life, and then any extramarital affair and extramarital sex, and then any infections for which he has just taken treated. Talk to him in detail and just record everything on the first thing. The examination, do not jump at the genitalia, start from head to foot. And as I was taught in the general examination, you start from head to foot, the hair distribution, face, and then the evidence of any abnormal loss of hair or a thyroid, breast, and then come to the local examination, have a detailed examination done, and then record the findings. There are a couple of investigations. Unlike female infertility, we have very few. One is the semen analysis, semen function test, hormone analysis, very few, and then genetic testing. So in the history, we ask about the duration of infertility, previous fertility, occupation, and causal frequencies, trauma, medications, surgery, all these details we recorded there. Physical examination, after the general examination, look at the penis, location of the urethral meatus, and palpate the size of this shape of the testis, consistency, whether the testicular funny sensation is present, any tenderness, and palpate for the vas and epididymis, and then finally do a digital rectal examination. When you see the cause for male infertility, you will see 31.7%. We don't know what is the cause. So we put it as idiopathic. The next is 16.6% is varicocele. Third is the male accessory gland infection, what we call it as an infection, MAGI, hypogonadism, cryptorchism, malformations, systemic and immunological causes, tumors and obstruction, and there are some other causes. So predominantly, we do not know what has caused the male infertility. The first and foremost is the semen analysis. And there are a lot of things we have to talk to them before just giving a slip and sending them for semen analysis. So avoid sexual activity, no sex, no ejaculation, and that is not no masturbation for at least about a week. And they should not have a prolonged um, abstinence. That is again detrimental. No smoking, and lubricants like saliva should not be used. Do not ejaculate into a condom unless it is provided by the lab. Semen analysis should not be exposed. The collected sample should not be exposed to extremes of temperature. Inform the doctor if you have been taking any medications. And then wash and dry the hands and penis before collecting the sample. And the container provided has to be at least about 75 times the expected volume. For example, 1.5 ml you are collecting, at least give him about 100 ml volume. Do not give him a penicillin bottles and small narrow tubes. Normal volume of the semen is about 1.5. So give them a container, wide mouth, sterile, non-toxic container, about 100 ml. Ask him to ejaculate directly into this sterile, clean, dry container in the clinic or in the lab. Try to get the first part of the ejaculate, as it will be the most sperm rich. And keep the specimen container upright in a plastic bag with the lid sealed tightly covered. It should be brought back to the body temperature and deliver it in the lab within 30 seconds, 30 minutes. And check the label of the semen container, label, name, time, age, registration number. Carry the ID proof while submitting the sample so that we can be sure. There may be some difficulties in collecting the sample. Some might feel awkward to collect the sample. And somebody who is going to knock at the door after you just go inside, it's going to be very difficult. Some cannot collect the semen just because of the mental stress. They may face difficulty when the problem because of the erection. Some people have a good erection, but will be unable to ejaculate there. So we have something called the non-toxic condom. And you will know that the condoms probably around 10 to 15 rupees, whereas this non-toxic condom will cost you at least about 900 rupees. And especially it can be used for a night falls where there is a nocturnal emission for them to collect it. And there is vibro ejaculators are useful, and it is hardly about 2000 to 2500 rupees. It should be kept in the room where they're collecting. They should be informed about it. Finally, there is an electro ejaculation. If the prostatic massage fails, prostatic glands can be stimulated using a small probe inserted through the anus under anesthesia. But however, the quality of the sperms may not be that good. A semen container collection room has to be clean, neat. This is our semen collection room in my SIMS hospital. And we use this simulator. You will see here, there is a place where they can just put a non-toxic condom and then collect it, and it will produce rhythmic contractions which can be controlled. Both the frequency and the power of the contraction can be controlled. There is a small video here with which they can see and then contain. So this is a very, very useful equipment, but it is quite expensive, and we have been using it in case of the difficulty in collection there. This is one of the greatest involvement advancements is there. Macular counting chamber, put a drop of liquid semen. No, nothing is added. You just put a cover slip and then look into the microscope and directly count it there. If you look at the reference values, it has been changing. When I was a student, it said 60 million, then came 20 million, then came 15 million. Today, even the new thing has come, and it needs only about some 15 million, and then it needs a progressive motility of 30%, and with the normal form of 4%. So this is the WHO. You will see that it varies from 2010 to 2020. There are a lot of changes are going on in the count as such. Very, very rarely you come across endocrine evaluation. If there is a sexual dysfunction, when the sperm concentration is very poor, other clinical finding that suggests specific endocrinopathy, you look for endocrine evaluation. The tests are serum FSH, total testosterone, LH, prolactin, thyroid stimulating hormone, and serum estradiol level. This is how you imprint. Primary testicular failure, both FSH and LH will be elevated. Testosterone will be normal or decreased. If it is a testicular failure with germ cell loss, FSH will be elevated, LH will be normal, testosterone will be normal. Testicular failure with maturation arrest, all of them will be normal. Obstructive azoospermia, all of them will be normal. And then when there is an androgen receptor deficiency, you will have an elevated LH and elevated testosterone, whereas FSH is normal. This is how you interpret what is the problem. You have semen quality analysis, where you do the counting, morphology, motility all together. This is one of the machines called sperm quality analyzer, where you just feed a drop of the semen in a provided capillary into the thing. It gives you the entire printout of this thing. This is what we use it for a primary just screening. The other advantage is CASA, where it is a standard method acceptable for levels of accuracy, but the errors can be avoided, especially in a research institute. It will be useful, but however, the initial establishment cost is very high. Beyond the testing, the routine semen analysis, there are some tests what we could do it as a DNA integrity testing and Y chromosome microdeletion testing. DNA integrity testing, where it is a normal Sperm chromatin is essential for the paternal genetic transmission. So if there is a DNA damage, it can result in infertility, recurrent pregnancy loss, poor outcomes in IUI and IVF. So we quantify the sperm DNA strand breaking, and we use the specimen as semen, and the various techniques like SCSA, tunnel, comet, and halosperm, all of them have been used, but gold standard is SCSA, and this is the marker for sperm function. Unexplained infertility, you will find it. Candidates for IUI and IVF, you can do it. If there is a recurrent pregnancy loss, you can do it. The flow cytometry is what we are using it in SCSA. This is the equipment which is available for SCSA there. You look at this, and if there is a low DFI, the live birth rate in an IUI goes as high as about 20%. If the DFI is more than 30, you will see that it has gone down to 2% there. Similarly, when you look at that IVF and ICSI, when the DFI is more than 30, you have to do directly an ICSI because ICSI gives you 50%, whereas IVF gives only about 30%. So this is how you try to modulate the mode of treatment with that. So Y chromosome microdeletion, it is a deletions are caused in the spermatogenetic failure. And men with obstructive azoospermia, we have to do it before we take a biopsy. And it is a PCF or the long of the Y chromosome, we analyze it there. The sample is only from the blood. It predicts the chances of finding the sperm in the sperm retrieval technique. If there is no microdeletion, you will be very confident that you will be able to pick up. If there are some deletions, then you know that it is difficult. For example, you see this is the Y chromosome, and if you have that A is deleted, it shows it is a germ cell aplasia, and there you cannot retrieve any sperm. And if B is deleted, it is a maturation arrest. There again, you cannot retrieve any sperm. And if C is deleted, if it is hyperspermatogenesis, 70% chances of retrieving. So if there is no deletion, and it is favorable where you will be able to do it up. We also do a CFTR gene analysis. It is very useful in azoospermia evaluation. But along with this, you have to screen the wife also, because sometimes the wife may be a carrier where you think everything is normal, but somehow or other you will have an outlink with the CFTR. So that is the reason it should be done for both partners before we plan for ART. With all this, the medical management is a very limited role. We use antibiotics for male accessory gland infection. This antibiotics has to be 2 or 3 antibiotics on a rotation. During the course of an antibiotic, you ask the patient to go in for a repeated ejaculation. And in case of a hypogonadotrophic hypogonadism, we can use gonadotrophin, either HCG alone or HCG and HMG, or FSH and HCG alternatively. And if there is a proven hyperprolactinemia, there is a place for bromocriptine and cabergoline. Cabergoline is advantageous because it is weekly once, and there is a place for antioxidants. Why the antioxidants? When and how to use the antioxidants? See, the seminal reactive oxygen species in a female, it is less when compared to that of a male, infertile male. So here you will see that they have taken a sample of all the men, and fertile men, again, it has got an ROS, but infertile men, it has got an ROS which is higher than that of them. What actually is the principle behind it? It can cause a male accessory gland infection, prolonged the stasis of the spermatozoa, and there may be a systemic pathologies like diabetes, cancer, or systemic infection, pollution, smoking, drug, environmental, all of them can cause oxidative stress. There may be a spermatozoal dysfunction, infertility, and then when you evaluate and treat the oxidative stress, then obviously it will be useful there. There are a lot of evidence to say that the antioxidants use is definitely improved. So these are all some of the earlier studies they have just done. They have just given, and then they have found the results. There is an increased DNA fragment, improved DNA fragmentation. Antioxidant treatment has been associated with the Cochrane reviews in 2011, where they have mentioned in number of studies with about 200 participants with effective thing. They have found out that definitely it is very useful there. It improves the outcome of live birth and pregnancy rate for subfertile couples undergoing ERT. So antioxidant is a very useful treatment. What antioxidants? When is it always or how much? Vitamin C, vitamin E, folic acid, zinc, selenium, how long we have to use it. This is one of the trials. I have done it in India on multicentric, randomized, double-blind trial. All the patients will be taking the tablet. One will be a placebo, which nobody will know. The other will be the true drug, which only at the end of the trial, we open the package and see which is normal and which is abnormal. So this was conducted in my center, Bharati Karla, and Ajit Saxena, Dr. Sonia Malik, Kapil Kochar from Indore, Sanjay Karla, and this is the study where we have just done that. You see, the Cochrane Library is one of the most highest authority you can say that they just show whether the study is normal or abnormal or subnormal. So here you will see that in Cochrane database in 2014, they have reviewed. So there is only one study out of the 6 studies placed in the awaiting this update, the review is from my study. The remaining studies as found to be screening, and then they have just been eliminated. So this has got a highest strength, and with which we have just done the study and proved saying that antioxidant definitely improves this thing. Now the new concept is only for about 60 days. Do not give for the entire spermator thing. So we have spoke about the antioxidants. We spoke about the hormones. We spoke about the male accessory gland infection. Very rarely, if there is a estradiol testosterone ratio is lower, there is a place for letrozole or clomiphene. Not like the female dose. Half the dose on alternate days will be ideal. So next to that, we just come to the surgical management of male infertility. The first part will be on the surgical treatment of varicocele. So here we all know there is an increase in venous obstruction, there is an increase in scrotal temperature, and decrease in the cleavage of the unwanted toxic materials. So accumulation is there. All this leads into infertility. So if you do a varicocele surgery, there is a restoration of the fertility. Spontaneous pregnancy can occur. It can be done through the inguinal approach, through the scrotal approach, through the laparoscopic, and we can also do the embolization. Inguinal approach has got the greatest advantage because you can include the cremastic vein, which cannot be done through a laparoscopy. So because it is only inside the inguinal canal is the cremastic vein. I myself has done about 1,000 cases those days, where it used to be a bilateral varicocelectomy. We can do it in about 45 minutes. But the point is now with so many new antioxidants and lifestyle modification and ART, it has gone to the backseat there. So they have seen there is, even the study in fertility sterility, the value of varicocele treatment shows the favors treatment there. You will see that it definitely favors surgery. So it can improve the success of ART. Even in case if you have a borderline varicocele and when you are planning for a ICSI, then it is worthwhile doing the varicocelectomy. So there are a lot of international studies where they have seen the pre-ops and post-ops, where post-op varicocelectomy, the number of sperms have been increased, and then with that, you will see the fertilized eggs were more, live birth rate was more, miscarriage rate was less when you treated the varicocelectomy is there. So varicocelectomy before the sperm retrieval, again on the treated, you will see 53% in the untreated, which is about 30. So if you have a documented varicocele, it's worthwhile doing it, even if you are doing it. What about azoospermia? Do you think it is the end of the road? Normally, we say that if there is an azoospermia, go for a donor insemination. Now, detailed studies have come where we find out whether it is an obstruction or non-obstruction. If there is an obstruction, normal sperm production will be there. It is a mechanical blockage, and it is a mastectomy, and it could be a post infection, and maybe, or it is sometimes congenital. And it is a non-obstruction, sperm production is deficient or absent, and there may be cryptorchism or architis. It may be following a chemotherapy, trauma, genetic gonotoxins, or it could be unexplained. Previously, what we used to do is we try to do a vasostomy, end-to-end anastomosis. We take a 3O with a straight needle, thread from one end to another end, and then do an anastomosis on top of it, and then remove the straight needle there. So the chances of success, if there is a tubal block, when you do it after a tubal sterilization, when you reverse it with a microsurgery, your result goes as high as about 60%. Whereas here, it is much less. So that's the reason it is there is an anti-sperm antibodies also plays a major role, and that is the reason we are not taking it up that easily with the vasovasostomy rather than going in for ART. The ART, there are a lot of sperm retrieval techniques are available, PISA, TISA, and TISA. Percutaneous epididymal sperm aspiration is PISA, where you put in a simple needle, and even with mild anesthesia or even intravenous, you will be able to do it. Sometimes you will be able to even do it with the local. So you can even use a scalp when set, thread it, then aspirate it, and you will be able to take it out there. The percutaneous, if these are all the different causes where you will be able to retrieve in a case of obstructive azoospermia. Post-infection and genetic, you can go as high as about 10%, you will be able to take it out there. The testicular sperm aspiration is again a negative pressure is created, and then you inject directly into the testicular tissue and then aspirate it there. And if it is a non-obstructive azoospermia, then you have to think very seriously with it, because even the size will be very small. You have to look at the FSH. FSH should be normal. Look for a Y chromosome microdeletion. There should not be any Y chromosome microdeletion. Then you can just plan this TISA. So both TISA and TISA are okay, but when you just come to the micro TISA, where you completely bisect the testes and then look for the sperms and then analyze wherever there is a fluidic portion from which you just take a sample, it is more. It is time consuming. It might take about more than an hour or two, but it is worthwhile. Your chances of getting a sperm in a micro TISA in a non-obstructive azoospermia goes as high as about 60% there. But whatever is the sperm, you take it out of that, we have to use it for only a ICSI. This is the ICSI where you just hold it and then just inject it there. Another advantage is to go in for an IMSI. So IMSI is use the highest magnification. When you look at this, these are all the defects where you will see the defects, you will see these defects when you do it in a magnification. If you don't do a magnification, 40x, you will see only a sperm. So if you do it at a 6,600, then you will see this is the kind of a thing you can select and then do it. This is again a time consuming where you have to spend a lot of time. That is the reason most of them are assisting. This is the IMSI microscope with which they just evaluate and then take it out. Another method of selecting the sperm is a PICSI, which is called physiological intracytoplasmic sperm injection. The Petri dish is coated with certain chemicals like hyaluron, and where the active motile sperms come and bind with hyaluron. So whatever is just taken from that strip, for example, you draw two lines with hyaluron and just keep it there. And whichever comes, gets attached to that line, you pick it up and then try to do it there. This is a very simple hypoosmolar swelling test where you prepare a hypoosmolar swelling solution, incubate it with about 5 minutes to 10 minutes in an incubator. You will see the tail will be swollen about 5 times, So if it is swollen, then it shows the good membrane integrity. So that you will be able to just pick it out and then try to do a thing. We have magnetic activated cell sorting called MAX. So here again, it is just the EPS DNA fragmented sperms have an affinity for a labeled annexin conjugated magnetic spheres. So you put it in the magnetic spheres, and then the weak magnetic field separates out the apoptic sperm from the best treatment sperm. With that, you will be able to do it. Even you can do a IUI with the MAX. Here there is another new system called Zymote Fertility has come out, where it is a small Petri dish here, and you inject the semen into the hole like what it has been shown. You smear the culture medium in the center portion, you smear the culture medium, and then after some time, you will see that they will just come out, and then that when you just take it out, you get the best thing. We have tried it here, and 98% motile sperms we will be able to get out of this procedure there. Whenever we try to do with the male infertility, especially with the TSA and with the following micro TSA, an advanced procedure, probably you have to just plan for pre-implantation genetic screening to make sure you get a good embryo and then improve the success rate. So this is very important. And you can do it on a blastometer on a day 3 biopsy, and day 5 biopsy, blastocyst biopsy is more standardized and more useful, and we have been doing it there. Now we come to the last part of the talk, where what is beyond male infertility? We always try to get them. Once when they become pregnant, we forget about it. So if they go in for a donor insemination, we do a donor insemination. If the patient, if she become pregnant, you just forget about the couple. So that's a normal happening so far. Now what they have done is, the male infertility is a biomarker for both individual and familial cancer risk there. So there's a big study which they've just come out. With that, what they have just found out, and there are various reasons, male infertility, there is an increased incidence of testicular cancer. One is hormones. So when there is an increased elevated levels of estrogen in the circulation, they produce some dysregulation. With that, there is an abnormal spermatogenesis, which can result in testicular cancer. Second is the genetic cause, where the genetic background may be a reason for male infertility. There is an increased risk of infertility than testicular cancer there. Third is on the environmental factor, possible risk between the various smoking and the testicular cancer, and various things probably can lead into the cancer. Lastly, the testicular abnormalities. There is a cryptorchism, abnormal testicular development, and then completely a non-obstructive azoospermia. So they can produce they can predispose to the testicular cancer there. If you look at the age distribution where the cancers come from, at the less than 5, you can get into a acute lymphoblastic leukemias, and then in around 35, 33 years, you can get a testicular cancer. When it is 45 and 54, you can just get a melanoma, or 63, you can get a thyroid cancer. Even at 65 to 74, you can get a prostate cancer. And 66, you get into a non-Hodgkin lymphoma. This is the in a male infertility. The strongest and most studied relationship between the male infertility and malignancy is with the testicular cancer. There appears to be a direct relationship between the male infertility and the development of high-grade prostate cancer also. Being childless may decrease a man's risk of developing the prostatic cancer. So obviously it goes in for it. Relatively less is known about the risk of subfertile men in developing other type of cancers, although elevations in the rates of melanoma, bladder, thyroid, Hodgkin's and non-Hodgkin's, and leukemia has been noted. So the key message there is you don't stop with treating them infertility. Either you follow up or advise them to go to a specialist for a routine screening, ask them to put them onto a urologist or an andrologist or an oncosurgeon to make sure they periodically they follow up in their lifetime and avoid such drastic events which comes out as a surprise. We have an opportunity, we will use it to make sure that we just do it. So to conclude, antioxidants are helpful to decrease the oxidative stress. Interventions impact on the quality 60 days later. WHO has lowered the semen analysis reference value from what it was. Sperm DNA integrity and Y chromosome microdeletion testing are a prognostic value in selecting the correct method of treatment. Treatment of clinical varicocele prior to ART benefits the patients and subgroups. Sperm retrieval and reproductive potential is dependent upon the type of the azoospermia. Example, if it is a non-obstructive azoospermia, it is very poor. If it is an obstructive azoospermia, it's much better. Long-term follow-up of malignancies, you have to create an awareness with the patient, with the referring doctor, and ask them to follow up forever to make sure that they don't miss the bus there. Thank you very much for your patience listening. I thank all of you, especially Shield Connect, for having given this opportunity to cover this spectrum. Thank you.
Thank you very much, sir. We are very honored and learning to hear you, sir. And sir, if you allow me, then we'll take the questions.
Sure.
Sir, we have first question.
Yes.
That is, in azoospermia, after how many days should semen analysis be repeated?
Ideally, we leave it for about 2 weeks and then repeat it. On 2 occasions, if it is azoospermia, then you directly go for further evaluation like FSH, Y chromosome microdeletion, and then TISA. Do not do testicular biopsy in a place where you don't have an access for ART. If you are able to get some sperm, you should be able to store it and use it for ART. If the patient cannot afford an ART, do not do the biopsy.
Thank you, sir. We have one more question, sir. That treating erectile dysfunction in diabetes can improve the sperm count?
No. See, the point is the erectile dysfunction is going to give only a performance improvement. So you have 2 important factors. One is erection, another one is ejaculation. So you find out what is the problem there, if it is erection or ejaculation. If it is only an erection, then you have to just give substance like sildenafil citrate and improve. And if it is ejaculation, then you can use a vibro stimulators and then vibroacoustic stimulators and then try to just help them to ejaculate. Sometimes the duloxetine does help. If it is combined both, then you can use sildenafil and duloxetine together. All this in a diabetic patient is only for performance. It is not for improving the count. If it is for improving the count in them, look at that estradiol testosterone ratio. If the ratio is less than 1:10, then you put them on clomiphene citrate or tamoxifen or letrozole on alternate days and then improve the counts, and then probably you will be able to achieve a count.
Thank you, sir. We have one more question, sir. Oligospermia, how to treat?
Yeah, if there are three entities. One is normal sperm, second is low sperm, third is no sperm. We discussed in detail about no sperm. Now this question is about the low sperm. The first one, you see a case of oligoacinoteratospermia. The first common thing is to rule out male accessory gland infection. So you give about 2 or 3 doxycycline, clindamycin, azithromycin, 2 or 3 different antibiotics, and then ask them to go in for a repeated ejaculation, that is, or at least repeated intercourse during that time. They should not have abstinence. So with that, you will see that it will improve. That is number one. Second, if there is a failure of improvement in spite of the treating a male accessory gland infection, then you look for varicocele. And if there is no clinically demonstrable varicocele, then you have to just go in for the treatment with the clomiphene citrate 25 milligram on alternate days, or letrozole 2.5 milligram half tablet on alternate days for about 60 days and then try it out. If it still doesn't work, you can go in for a human chorionic gonadotropin, at least 2,000 to 3,000 units once in 3 days for about 60 days. So if this does not help, then you go to the next highest point where use HMG followed by HCG for about 60 days.
Thank you, sir. We have one more question, sir. That is, recently we are seeing more 100% necrospermia. What is the reason? How to treat it?
Yeah, necrospermia. If the patient comes to me, the first thing I will think is whether it is collected at home or here. What is the time difference? If there is a large time difference, then probably it can be a necrospermia. The second is, if there is a necrospermia, you have to put a urine stain and see. And if they take up the stain, then they are all dead sperms. If they do not take up the stain, it is only a necrospermia. So you have to identify between the live sperm and dead sperm. Then if there is a dead sperm, and then you know that the first commonest thing is the time. Second is the male accessory gland infection. So this two to be addressed. And if there is a live sperm which does not take out immotile sperm, then probably you have to very seriously think in terms of looking for varicocele and correct it, or to subject them for ART.
Thank you, sir. I think there are no more questions from the delegates, sir. If you allow me, then we'll close this webinar.
Thank you. Thank you. Thank you very much.
Thank you very much, sir. We are very glad to and honored to have you, sir. We look forward for your continuous support, sir.
Thank you. Thank you.
Thank you so much, sir. And many thanks to all the delegates for active participation.
Thank you. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you, Balaji.
Sir, wishes to Joshua for his birthday.
Sure. Thank you.